Welcome, everyone. As she said, come on up close so you'll be able to see her screen. Okay. So, on behalf of NHF, welcome to Musculoskeletal Ultrasound now and in the future. My name is Jennifer Shack, and I'm with the Hawaii chapter of the National Hemophilia Foundation. You can fill out your evaluation on the National NHF Bleeding Disorders Conference app instead of the paper form, which we have highly recommended, and there is a raffle in the app evaluation. Please fill them out as they can help us plan for next year. At this time, I would like to introduce Cindy Bailey. She's our session speaker. Thank you.
Can I take this off?
I think so.
Yeah. I like to walk and talk. So welcome to this course. This session is going to, you guys are the bold that stayed till the last part. So you get the funnest session. So this session is going to be about ultrasound, and it's going to be very educational, but yet it's going to be really fun to see what we can see from the outside of your body when we don't have to cut you open, which is kind of nice. So this is ultrasound. It's the same kind of machinery and mechanisms that we use for when OBGYNs are looking at babies, but we're looking at your musculoskeletal system, right? So we're going to get going, and this is going to be kind of rapid because I have to be at the next session. So it's going to be fast. So the use of ultrasound, number one, I have no disclosures. Well, I have one. I am on the Speakers Bureau for Sanofi, but I only speak about ultrasound. It's the only thing I'm on their Speakers Bureau for. I have a specialty in orthopedics, a specialty in sports, and I also have taught at the University of Southern California as well as several other programs. And they are all within the sports realm. My whole world is orthopedics. So that's what I do. And now my two worlds of sports and hemophilia, which I've been in hemophilia for 25 years, those two worlds are colliding, which is kind of cool because more and more kids are being able to do more activities and more sports related things as the prophylaxis gets better. When I first started, we didn't have any. I mean, we would tell kids don't play sports. So this is really such a different lifetime than 20 years ago when I first started this, and there were really no products. So what you're looking at on the screen there is an ultrasound console machine, much like you would see in an OBGYN's office, or if you went to an imaging center, if your doctor referred you to an imaging center. And some of the HTCs have those now. We certainly do. This is my machine. And I wanted you to see the very first slide. This is what it takes to do an ultrasound. I already have gel on my arm, and I want you to look at the arm where I'm going to put the probe and how quickly it comes up on that screen. Okay? Do not blink. Here we go. There it is. And I can tell if there's blood in that joint right now. Okay? So we use this tool for multiple things. We use it for yes, no. Yes, there's blood in the joint. No, there is not. Now, some joints have pockets around them, like the knee especially. The ankle is kind of difficult sometimes. So at times we have to go and look for it. It's not quite as easy as that. But many times it is that easy. And you can go, oh, wow, okay, that's a recent bleed. And we can also tell by ultrasound the age of the bleed to some estimate degree. Okay, is it fresh? Is it a week old? Is this really old and now you have synovial thickening? That type of thing we can actually detect with our ultrasound machines. So we will go through this, and now we'll go through the icky stuff that you have to pay attention to a little bit. So what is it and how does it work? So ultrasound is exactly what it says. The ultrasound is a sound head. Here it is. And it's as it transfers, but this is a two-directional sound head. So the therapeutic ultrasound I use in my office for generating deep heat before someone stretches, scar tissue, things like that. That's a different kind of ultrasound. That's called therapeutic ultrasound. This is imaging ultrasound, very different. This creates no heat in the tissues, has no radiation, has no other problems that go along with it. This is I could leave it in one spot for 5 hours and it doesn't do anything. Okay, so this is a two-directional. This sends the sound wave out, but then it also has a receiver that receives the sound wave in. And that's what makes this very different than any other ultrasound that you would see in a physical therapy department or something like that, is this is imaging ultrasound. Okay. I was trying to advance my microphone. It doesn't work. Okay. Now, the thing that you'll see, the gray images up here, the different shades of gray in this image, tell me what it is. We'll go through this at depth, but it's the lining of the bone, the muscle, the capsule, more muscle, and then you have skin. So those different shades of gray are made because this sound that's coming out of the sound head, when it hits tissues of different density, like a bone is different density than tendon, which is a different density and gives different resistance than skin or of fluid. So based on how hard the sound beam bounces back, gives me a different color gray. And that's how I can tell the difference in my tissues there. Okay. So the density of the tissue sends the sound wave back at a different speed. And that's going to give me my different shades of gray. So we use ultrasound now for guided imagery. We still use it for OBGYN stuff, but we also use it for musculoskeletal issues. We use it for guiding needles to aspirate joints that have had bleeds, like where is the biggest pocket of blood? So where can we draw that blood from easily? So we don't have to go hunt for it with a needle. I'd rather hunt for it with an ultrasound machine and then stick a needle in the most appropriate point, okay? So aspirations and injections with ultrasound imaging works really nicely. The machines run from a very, very costly machine, which is the kind that I'm lucky enough to have, to a laptop, to a handheld, which is the one I have right here, okay? And we'll talk about those. Most centers will go with the one that they will use the most. You only need the great big giant machine if you're going to do research. So if your center isn't going to be involved in a lot of research, they probably will get a laptop or a handheld, which is appropriate because they're all really good imaging tools. It's totally fine. Just on the big ones, you can relabel, you can do measuring, you can do a lot of other stuff. Like once the patient is gone, we can do a lot of what we call post-processing on the big machine. Okay. When MSKUS is preferred imaging modality, which a modality is just a gadget. It's a preferred imaging because there's no radiation. So you're not exposed to radiation like you are with a CT scan, and you're not exposed to any magnetic energy like you are with an MRI. And X-ray has radiation, obviously, that's what it does. We don't have to sedate children. So if you give a child an MRI or a CT scan, a very small child under 3-4 years old, many times they have to be sedated. And with ultrasound, we just distract them with a toy and ultrasound what we want to ultrasound. Okay, so it works much, much nicer for children. There's no thermal effect, as we discussed. There's no chance of heating the tissues. And so you can hold your probe in one place and really hunt around for what you're looking for a long time if you need to. It's available immediately in clinic. Now, this is the key for hemophilia treatment centers. If you come in with a swollen something or a painful something, but it doesn't look swollen, we can determine immediately on that visit, are you bleeding or are you not? Guess what? We did studies, and 50% of the time, the patients are wrong. And guess what? We did another study, and 50% of the time, the providers were wrong. And so really, to get a good look at, are you bleeding or are you not? This is really the only definitive way to do it, unless we send you to an imaging center. Well, if we do that, we have to wait for them to schedule you. Then we have to wait for your insurance authorization. Well, it goes the other way around. You wait for the authorization and then you schedule. So you might go get that ultrasound 2 weeks, 2 months later. Who cares at that point? You don't have the same problem anymore. Your problem is on that day. Are you bleeding or are you not? That's when we need to know. So if we have this in the center, we can tell the hematologist that immediately within 5 minutes, and they can determine whether you need factor, whether you need an anti-inflammatory, or whether you need to see the physical therapist and have them tell you not to do that again, whatever that was. Okay, so it's something that we can get you definitive treatment of what it should actually be on that day, and we're not guessing. So that's the best thing that we can do. Our guessing, we think, is pretty good. And usually we try to guess on the best side possible. So if we're not sure, they usually do tell you to infuse, okay? but it's better to just know. And so that's where it gives us a really nice advantage. Okay, so why is ultrasound really, really good? Ultrasound is better than an MRI by about 4 to 20 times. And that depends on if they're using a research MRI machine, it's probably only 4 times better. But if they're using a normal a normal MRI that you would get if you went to Tower Imaging down the street because you referred to Tower Imaging to go get an MRI, then it's about 20 times better than that MRI. And this is why. When we look at voxels, which are the same thing as pixels on your TV, but because this is more of a depth and a 3D image, then you get what we call voxels. So the voxel on your MRI machine is this big. The voxel on a ultrasound machine is this big. So the smaller the voxel, or the more voxels per screen, the better your image is going to be, just like a TV that's 600 voxels versus a TV that's 1500 voxels. Okay, your 1500 voxel or pixel TV is going to be a better focus than your 700 voxel or pixel. And so when we're talking about MRIs versus ultrasound, ultrasound has a much more defined image than an MRI does. Why would we want an MRI then? Because ultrasound can't see through bone. So we can see the surface stuff, we can see the pockets of fluid, we can't see an ACL ligament. We can't see a PCL ligament. We can't see, so the things that are deep inside, we cannot see with ultrasound. Okay, we can only see it if it's on the surface edges. Meniscus, we can see the outside edge of the meniscus. We can't see the inside edge of the meniscus. You'd have to have an MRI for that, right? So there are reasons to still have both. The other reason, which is really important, is that MRIs only cut for an image every 4 millimeters. So it cuts every 4 millimeters. See the spaces in between those red lines? Well, that's not being imaged by an MRI machine. The only portions that are being imaged by an MRI machine are the spaces where there's a red line. So the MRI machine takes those cuts and averages them in order to get a picture that it sends onto the film that sends to the doctor to read it. With an ultrasound, you're going like this with your little ultrasound gadget, and you're getting every single edge. So there's nothing that's going beep, beep, beep. So I'm not getting a picture in between those areas. I'm getting an image of everything, okay? But when it goes deep into a joint, obviously I can't get that, so you need an MRI if it's inside the joint. So we not only don't have to average it, we get everything. So we get a much better image and idea of what's going on. It's a preferred modality for fluid because an MRI or a CT scan can tell you, yes, there's fluid there. But the ultrasound machine can say, yes, it's blood, or no, it's not. Yes, you have a lot of fluid, but it's just joint fluid because you're inflamed, versus, no, you have fluid and it's over 5% blood. So when it becomes 5% blood or more, which if you have a bleed, it's way more than 5% blood. So if you have more than 5% blood in the fluid, those little heme molecules, which is the iron part of your red blood cell, is the heme. So the heme particles become a reflector. And so when that becomes a reflector, it reflects this image this sound wave that's coming out of the transducer. It hits the heme or the iron, and it bounces back harder than the fluid around it. So it's going to be a speckle. It's going to be a grayish little speckle. So if it's clear fluid, it's not going to do that. It's just black. Black shows up, fluid shows up as bright black. If it's a grayish black and you compress and you let up and you compress and you let up, those little speckles will swirl and move, and then we know it's blood. So it's really, and then we can see blood as it clots, and then it gets fibrin strands. Like I say, we'll show you a couple of pictures of healing, and you can see the blood looks different. Whoops. It looks different as it heals. So the evaluation with MSKUS is an extension of your normal evaluation. You would never go into an HTC or an orthopedic surgeon's office and they're just going to do ultrasound and then they're going to tell you what's wrong with you, because it's part of the whole evaluation. It doesn't stand alone. So you really need the entire hands-on, what happened to you? What were you doing? How did it feel? What was going on? Let me touch it, poke it, move it. Okay, now I think I know where the area is. Now let's see what it looks like. Okay, so it's not a standalone. It's always part of the entire evaluation. The treatment centers use it for yes/no questions, like we talked about. Is there blood? Is there not? We also use it for comparison of joints over time. So, okay, Johnny had a bleed when he was 7 years old, and now he's 13. Well, he hasn't had another bleed that he says is a bleed, but well, and so now let's see what that joint looks like. So we'll put an ultrasound probe on that ankle, and then we'll do it on the other ankle that's never had a bleed, and they look very different. Okay, and then we'll put and we'll tell Johnny and family, the ankle has already had some changes because there was blood in a joint. Blood is extremely detrimental to any tissues it's around. It's the enzymes, as the blood breaks down, the enzymes are not nice. And that's why it inflames all of the other tissue. Okay, so we need to get it out of there. I don't care if you had a car accident, you don't have hemophilia, you had a car accident, a sports injury, whatever you may have had, if you have blood in a joint, it's going to do the same thing, whether you have hemophilia or not. So anytime someone has blood in a joint, they've got to get it out of there as fast as possible. And you'll have less problem with it. So if we know it's there by doing an ultrasound, cool, we can get it out. If it's soon enough. If it starts to coagulate, then it's not going to come out with a needle. And you just have to wait over time. But there are things we can do to speed it up, as you know, if you go to your physical therapist regularly. So make sure you keep those visits. So we also can do Johnny's ankle when he had the bleed, Johnny's ankle 2 years later, and then Johnny's ankle 5 years later, and see how it's progressing. Is the cartilage diminishing? Is the cartilage regrowing? Because up until the age of 11 or 12, your cartilage will continue to grow. But after the age of 12, you don't get new cartilage. And so if you've damaged your surfaces before the age of 12, good for you, because now you have a chance to regrow. But after the age of 12, you have to learn to be nice and have to learn to factor regularly and stay on schedule, because after the age of 12, we do not regenerate new cartilage on our joint surfaces. So we can also do investigative, where we are looking at the ankle to see, like say with Johnny down the line, we can compare right to left immediately. Like if this is a child, we don't know them, we haven't seen them very much, they haven't had very many bleeds because they're on the prophylactic factors of today. So when they have a bleed, well, we've never seen this child, so let's take a look at the other side. So we can compare what's normal for this child, side to side. And then we also do a lot of research with these machines, and it actually is probably becoming one of the largest bodies of knowledge for orthopedics in acute injuries that then get followed up on. They have lots of ultrasounds of acute injuries in the emergency rooms, but those people don't come back. So our population is one of the only populations that's being tracked over time with healing of these things or worsening of these things as time goes on. So the body of knowledge we are developing with the ultrasounds we're doing now will be important for not only hemophilia, but general orthopedics as we move forward in medicine. So we thank you all for bringing in your joints so that we can ultrasound you. Okay. So the point of care ultrasound, we've already discussed that. It answers yes and no questions. Are you bleeding? Are you not? Have you had cartilage changes? Have you not? Is there tissue, soft tissue, or a hematoma problem? Are you progressing and healing, or are you not progressing and we need to really think about why you're not progressing? So it gives us a lot of data all at once. Point of care, it also answers those questions quickly. We can also do Doppler. Now, Doppler is something where it shows us microscopic blood flow. So when the blood is in the area, in the tissues, we know it's trying to heal because blood flow shouldn't normally show up on a Doppler. I'm not talking about color Doppler. Color Doppler is, do I have a blood clot? That's like, which way is the blood flowing? To my heart, away from my heart? That's a color Doppler that vascular medicine does. That's not what we do. We do it for inflammation. So we're looking at microscopic itty bitty capillaries. And so if the screen, we turn a certain button here and it'll show up with red percolating dots if there's a lot of inflammation in the area, because those are your microscopic little blood vessels trying to bring fluid into the area to promote healing and bringing new nutrition, carrying away waste product. Okay, so we can tell if there's a lot of inflammation in the area as well. Dynamic imaging is another one. So dynamic imaging would be, okay, my ankle hurts when I do that. Okay, well, wonder why. Okay, with ultrasound, I can put the ultrasound on it and say, okay, do that. Oh, looky there, you have a bone spur that's going every time. So that will be a really nice thing for physical therapy to be able to do, to go, oh, okay, we're not going to have you do that exercise anymore because you're just scraping your cartilage off the other side. All right. And let's refer you to an orthopedist who can say whether or not they think removing that bone spur would be successful or not. Some of them are in places where they're successful to remove them. Other bone spurs are in places where they're like, if we take that off, it's just going to come back. Okay. So the orthopedist can give you that information. When we do ultrasound and the longitudinal comparison, like I said, we already talked about that. You compare it to the previous scans, and you can compare it to the opposite side. Investigative, that's when we're looking at things to see what we can find, to see how it looks from time to time. How did it look last time? How does it look the next time? Is it healing or is it getting worse? And then we can refer to what we need to, whatever doctor, the orthopedist or the hematologist to go, hey, maybe we need to change dosing, maybe we need to change the product, whatever what we might need. We also have different protocols we use. You might hear people talk about JADE or HEAD-US. Those are all abbreviations for joint activity damage exam or hemophilia early something detection, arthritic detection ultrasound. So it's just abbreviations. It just means they're going to do an ultrasound. So on your joint. Okay. So research-wise, we do a lot of research. We're doing some research projects now, okay, we'll start ultrasounds, get a baseline on people, then they'll change a product or they'll use a certain product, and then we'll do more ultrasounds, usually for a 3-year period of time, to see how that product has done as far as their joint health. And so we're involved with 3 different companies right now doing research like that, and one institution who's doing their own provider-based study. And so it's really catching on as a nice research tool to see how patients are doing over time. The summary of positives and negatives. Again, the positive things are there's no radiation. You don't have to sedate young children. It's very inexpensive once you have the machine. The machines can be pricey, but once you have the machine, the providers in your HTC are already there anyway. So it's not like you have to pay somebody to go down to when you send to radiology, you don't have to pay the tech to do the imaging because you're already paying the HTC person to be in the HTC. So if your HTC is doing this, it's very inexpensive once they have the money output for the machine. So it's inexpensive. It can be done immediately in the clinic so that you can give the feedback to the hematologist immediately, and they can decide on a proper treatment for you. It is real time. We talked about that. And you can do immediate comparisons right to left, and the resolution is better than an MRI or a CAT scan. And we can tell you, is it fluid or is it fluid with blood? So ultrasound is the only one that can tell you that. And it's portable. You can get the little teeny ones like this. We took this one to Guam and Saipan and, flew it on the airplane. It's like easy. And we helped them do their clinics for a weekend or 2. So the drawbacks are it's operator dependent. So the person with the ultrasound in their hand has to be trained, and they have to know what they're doing, and they have to continue their updates on their continuing education. So it's operator dependent. The ultrasound is only as good as the pictures you're getting. So if you're not getting good images, you're not going to be able to interpret it correctly. So it really needs to be somebody that's well trained. And that you can't see inside the joints. You can only see the peripheral areas. So with ultrasound, what are we looking at? We talked about that. We're looking at the different densities of tissue, bounce back the sound at a different speed, and that gives you a different shade of gray. So that's what we're looking at. The fluid is black, And the tendons are just a different variation of gray because they're a little bit different density than bone, skin, or muscle. So all those tissues will look different. All right, so let's look at normal. When we have something that's normal, we have a muscle is 70% water. So if water shows up as dark black, that means that your muscle is going to be mostly black if it's 70% muscle. And so those little white striations and little white bands, it's like when you're looking at a steak, okay, those are the little separation in the muscle bundles. And then the thicker white stripes are the differences in the muscle fibers. So you have the differences in the teeny muscle cell, and then the muscle fiber, the muscle strand, the muscle bundle. So as you get bigger and bigger with your muscle fibers in groups, then those bands get a little thicker. The black here is cartilage, which is even darker black. So do we need to stay hydrated if 70% of our muscle is water? Yes, we do. And if 80% of our cartilage is water, we need to stay hydrated. You want healthy cartilage? You've got to stay hydrated. It's 80% water. So cartilage shows up as black. When we're looking at cartilage, it should follow the bone line exactly. If you have a black area, like this is the bottom of my humerus here. It's the bottom of my arm bone. And then that part over there is the square head is the top of the radius. So if I had a lot of fluid and a swollen elbow, I had fluid in there, I would have more black, but it wouldn't be following the bone line. It would be like, woo, puffy. And then I would know, okay, that's not cartilage because it's not following my bone line. And when you get a lot of fluid in a space and there's cartilage, you get what we call an interface sign, or a very, very light, significant white line. You can tell it's a line, but it's super light. And you can tell the differences between your cartilage that is exactly on the bone and the fluid above it has this teeny weeny line that you can barely see. And we call that the interface sign. So if you have fluid above cartilage, you can tell that because you'll get what we call an interface sign there. So when we're looking at peds versus adults, they're very different. And again, it takes training of the operator of the ultrasound to be able to go, oh, that's a normal peds, or oh, that's a normal adult. So this is an adult, this is pediatrics, this is a knee, this is a knee. It's the same picture, but one is on a child and one is on an adult, okay? So this is the femur, all the way down to where it goes. It's going to go around right under that blue arrow. It goes around, whoop, and down into the knee joint. So this is the femur on a child. It comes up here and oops, what did we run into? The growth plate. Okay, so child, you'll see an open growth plate. An adult, you won't see a growth plate because it's already closed, right? And then as we're born, when we're little babies, we don't have any solid bones. We have lots of cartilage, but our bones don't ossify or become bone for several years. And sometimes into 7, 8, 9, 10, 12 years old, you're still seeing weirdo changes like this, where you're like, what is that? And if you don't know the difference, you're like, wow, they have a lot of swelling. Nope, that's all cartilage. Do you see how that's a bone line? Well, look at this. It follows it exactly down into the joint. So this is all cartilage. That's not swelling. If I saw that on an adult, I'd go, wow, you're having a bleed, because that's a lot of fluid. Well, I would say that's a lot of fluid. It doesn't have any gray speckles, so I wouldn't call it a bleed. But then that's his patella. This is the patella. It doesn't have black around it. It just has black under it, which means that's the shadowing from the bone. So on this patella, that's a little bit of patella, but this is all cartilage, 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 cartilage. So there's no swelling in this knee. It's a totally normal pediatric knee. It's a totally normal adult knee. Okay, so you really have to know, the person doing the ultrasound has to be educated and take their courses and keep up on them. Inflammation and joint fluid, again, we look at that around where we see the cartilage, or if there are bones that don't have cartilage, because like right in here, there's no joint. So right here is a dip. So that's a place where fluid comes out of the joint. It'll push up that tornado sign. See that little V? We call that a tornado sign. And that's normal and good. That's a fat pad that goes down into the joint. All joints have those just to pad your bones one against the other. So if that tornado sign is pushed up, it'll be up in here with lots of black and gray swirls under here, then we know that that's full of fluid. And if it's speckly swirly, we know that fluid is blood. So, but another place it can go is right into the dip. Because if you follow this line right there, that's capsule. But see that space underneath there, right there? The fluid can come from here and go into that space. So it just fills that up with a little bit of black. And it also can come over here and fill up this dip. So wherever you have a dip, fluid can accumulate there. So we look in those pockets when we're looking for different things of, are you bleeding, are you not? Do you have inflammation fluid, do you not? And we look at what kind of fluid that is. So again, we already talked about the brighter black is pure water, then cartilage is dark black, and then we get our different shades of black throughout our tissues, depending on how much fluid or how much water they have in them. So when we're doing this, the best provider, like who does this best? Who would be the provider to do your ultrasound in your clinic? Anyone with a medical professional license is allowed to do ultrasound in the United States. And so, bless you, within your hemophilia treatment center, that could be the nurse, the physician, or the physical therapist, or the physician's assistant, or the nurse's assistant. So it could be any one of the medical providers are totally cool to do ultrasound. But you want to pick the person, or your ultrasound, your HTC, it's nice if they pick the person that knows their anatomy the best. So whoever that is. It usually is the physical therapist. Like say, we're better at musculoskeletal anatomy than anybody but an orthopedic surgeon. And so that's why it's usually passed on to the physical therapist. And we love it. This is like Disneyland for us. I mean, we're like, woohoo, look what we can see. So it's really something that is really nice. And if they don't have the physical therapist there on that day, who's going to do the ultrasound? So we always try to have 2 people from every center train to do the ultrasound, so that if one person is not there, the other person can do it. And they're very well trained, so they know what they're looking at. And you keep the little books handy. And then you can know what normal is. And you can go, does that look like normal? Wow, it does not. Okay, so there's something going on. So even if you're not a physical therapist and orthopedic surgeon, you can really get good at this by just having normal in front of you and going, that's not normal. So what is it? When we look at musculoskeletal ultrasound, we talked about the tornado sign and fat pads already. Okay, I got ahead of myself there. And we talked about the capsule, which is the thickening, the white around it. This thickened area is like a leather pouch. All capsules are very, very thick because they blend with your ligaments. So your capsule are the deep layers of the ligaments become the capsule. And that's why it's like leather. And so it's very, very thick, and that's why it's dense. And it returns back as a gray-white signal. Bright white is bone. The grayish white is capsule and ligament. And then you have tendon, which looks like a rope. We're not seeing a tendon yet. So once you know what normal looks like, which now you guys are all wonderful at this, you can go and do your ultrasounds and get normal. Now we're going to look at what pathology might look like if we saw it. Okay, one of these things doesn't look like the other. So this is a knee like this, looking straight down in it. So we see the notch where the patella will sit against it. So it keeps it right in that little notch. And so we're seeing what they call the femoral notch. And this is the bone. And this is the cartilage. Okay, this is a knee probably about 45 or 50 years old. How do I know that? Because see the graying of the cartilage over here? Okay, so, and this, I happen to know, like, who made the slide. So, so I know this is not a patient with hemophilia. This one is not, this one is. So this person's a little over 50, and we have some graying of the cartilage, which means, to me, cartilage is supposed to be black. So that person's cartilage is getting dehydrated. There's not as much fluid in it, and therefore it's showing more white, because things that do not have fluid, like bone, it shows up white. So as we get those little graying and the speckles in the cartilage, we know that it must be getting dehydrated. So this person not only needs to make sure they're hydrated, but do things that are not traumatizing to their knees. If they're a runner, maybe you should do biking or swimming. I mean, this is still a beautiful knee. I mean, that's a good amount of cartilage. You can see their bone is feathering a little bit. That's not a fracture or anything. That's just a little bit of telling us that the cartilage isn't as healthy, so it's not giving the bone as much nutrition. Okay. Now over here, this is a patient with hemophilia that has had multiple bleeds. So the bone, what happens to the bone happens after the cartilage. So first their cartilage started to wear away. See, they still have a teensy bit left right there. See where the dark, beautiful black is on top of that bone? Right there. And then a little bit over here. So they have a teensy bit of cartilage left on each side, but all of this, see, it does not follow a smooth bone line. This black that's going through here, it does not stay right with all those craggy points, so that's not bone. I mean, that's not cartilage on top of the bone, that's fluid. It does not follow the bone line exactly. It's not cartilage. So this person has almost zero cartilage left on their weight-bearing surface, right? This would be a very painful knee. And you can see where the cartilage is so bad, it's just more fluid, mucky in here. We call that soft tissue proliferation. It's not really a fluid pocket. And then I'm not really, I mean, in order to really say that definitively, I'd have to take my probe and do what we call sonopalpation. Palpation is just poking on you, okay? Feeling your tissues. So we would take the probe and we would press down, let up, press down, let up. And so we would see if that fluid, if anything moves or compresses, that would be fluid and it'd be swirling. If it doesn't compress, it's soft tissue proliferation. We call it that because we don't know if it's fat. We don't know if it's thickening of the synovium. We don't know if it's just a thickening of scar tissue. We don't know with ultrasound. We can make a pretty good guess after we've done these a couple thousand times, but we don't call it that medically because that's a no-no. So we would call it soft tissue proliferation. If you wanted to know what it was exactly, we're pretty sure it's synovial thickening. But if you really wanted to know specifically for a medical diagnosis, then you would get an MRI or a CAT scan because they can tell you what tissue it is. Ultrasound can tell you what fluid it is. Okay, so that's another difference. All right, this one over here, we have a nice, beautiful bicep. And so this is, as your bicep comes up your arm bone here, you've heard people talk about your bicipital groove, okay, where the biceps tendon runs, and then it comes along and it turns and comes up and attaches up here. So this is that groove, okay, and that circle inside there, that's your bicep tendon. That doesn't look like that. Your tendons should come, your other rotator cuff tendons come around right on top of that, and you have a little ligament that holds in the tendon, and then you have beautiful deltoid muscle. Where's your beautiful deltoid muscle? Oh, it's been pushed up, and it's way up here. All of this junky muck, that's a bleed. And see how it's gray speckly? This is a big fluid pocket. This whole thing is a big fluid pocket. And they actually had another one right here. So this would be a fresher bleed because it's more dark black. And because I took this image, I know that there were speckles when I did compression and let it up and compression and let it up. So this one was a fresher bleed. This one was a little bit older because the speckles were getting darker, and see how the speckles are trying to stick to the edge of the wall. And then you've got a different color gray in the middle right here. So this is probably 3 bleeds. They probably bled, this one's first because it's older and it's going more whitish and it's trying to stick to the side. They try to stick to the sides as they age. And then they had another bleed. That's a different age. And then they had another bleed that's more fresh. So we can tell a little bit about the bleeds that people are telling, and they're telling us their history. Well, you know, I thought it was getting better, but then on the 4th day, it swelled up again, and I knew I was having a bleed again, so I factored again, and then it was getting better. I thought I was good, and then, you know, a week later, I had another bleed. And so we can kind of track that with the ultrasound as well, as we see these different colored areas. Some is healing and getting clotted, and some is darker and fresher, even though it has the gray speckles in it when I push. Okay, so we can kind of watch it over time. Oh, that actually had a video, I forgot. Can you guys press the video back there? See if it'll do the video. There. So when I push down, you can see it misshapens my little pocket and comes back, and the speckles kind of move. So that's how we can tell that that's blood in the space and not just some kind of soft tissue. Okay. All right, we talked about that. Watch the speckles. We did. Oh, hey, I get to do it too. Okay. So, and this is after 2 weeks. Okay, Dr. Luck did an aspiration on that shoulder to get out as much blood as possible. And then after 2 weeks, look where the deltoid is. Oh, wow, it came down from all the way up there to down here. And now we're getting a nice, it's coming down to where it's getting closer to where it should be. But we still have all this thickened area inside here where the old blood is sticking to the capsule. Then we also have these fibrin strands that come across. We still have the speckles. We have the thickening where the blood is sticking to the walls of the capsule. All right, we see that very commonly in most bleeds that are trying to resolve. So when we're looking at this, now what's the future of ultrasound in your HTCs? So the future is, we just hope that all the HTCs get ultrasound. That would be good. But not everyone's going to be able to afford it. And so we understand that. And so talk to your chapters, talk to the folks who help fund your HTCs, because this one that we're going to see is, it was $11,000 when I bought it. It's now down to about $5,000 because they're becoming so common that they're getting cheaper and cheaper. So this is one that plugs into a tablet. I also did this when we were in Guam and Saipan. I actually plugged it into my phone. And we did it off of my phone. So they're getting smaller and smaller. So this company happens to have a component to it where it has a Skype and a FaceTime kind of thing. It's not an iPhone, but it's the same thing as FaceTime. And it will, got it turned on. Oh, what happened? Okay, so with the FaceTime option on this one product, you can call up the HTC, and the person can get on the Skype kind of phone call thing on the tablet with you, and then they can watch you where your hand is and where you're putting it, and they see the image on their screen, and then they can say, well, move your hand a little bit to the left. Move that a little to the right, go down a little bit, up a little bit, and they can see what the ultrasound is imaging. So they can guide you through it. So if you live 2 or 3 hours from an HTC out in the farmland somewhere, in 10, 15 years, you'll probably have one of these at home, and they can go, okay, well, let's do your ultrasound to see imaging, to see if you're having a bleed now or if that's just inflammation. So the future is, first, we just want to be able to have HTCs all be able to have these and use them. And some of them are institutional barriers where the radiology department wants to keep control of all imaging in the center, and they will not allow them to do it. I mean, in the whole hospital. They're like, no one does imaging except for radiology. I say kapooey on that, because look at all the imaging they do in the emergency department. Look at all the imaging they do in OBGYN. Look at all the imaging they do in rheumatology. That's where we got this from, is rheumatology. The rheumatologists do their own imaging. So I say poo-poo on that. So and we also have a lot of radiologists to back us up, to go, no, you guys are really good at this. So the future, we think, is number one, let's just see if we can drop the barriers to HTCs having their own. And number two, in the future, you guys that live at a distance will be able to do this and be guided and not have to drive 3 hours to see if you're having a bleed. Okay, so I would say that would be the future, the two things that we would like to see. And the summary again, no radiation, no sedation, it's inexpensive. You can do a comparison right to left immediately. You don't have to wait for authorization or a referral. And you have excellent imaging resolution, better than an MRI or a CAT scan. And so it really is a nice tool to have, and it's portable. The cons are that it's operator dependent, so it's only as good as the images that I get in order to interpret them and give my hematologist or my orthopedic surgeon the information that they need. So it's only as good as the operator, and we can't see through bone. That's about it. So now, because we have people online, we want to take questions for those online, because the online folks, it's not set up so that they'll be able to see the in-person demo. Come in person. Okay, so so they won't be able to see the in-person demo, and we're sorry about that. We just didn't know the configuration of the cameras. So we're going to take questions first, if there are any from online, and then we're going to do a little demo.
There is one question so far. Is there a way to differentiate microbleeding from inflammation related to some sort of rheumatic disease?
Yeah, if you have microbleeding, you're going to have blood in the area. So you'll have if you go to your center, there's no way to determine that if you don't go to your center to get imaged. But if you go to the center to get imaged, well, the one way to find that out, if you don't go into your center or you don't have imaging, is to give yourself a dose of factor and see if your pain goes away. If your pain goes away, it was a bleed. If it doesn't, it's inflammation. That's the old way, okay? The new way would be get your tushy on down to your hemophilia treatment center, and we will ultrasound it, and we'll see if you have blood in the area. If there's blood in the area, it won't just be clear fluid. It will be clear fluid with gray speckles. Okay, so if there's blood in the area, even from a microbleed, small oozing, whatever you want to call it, you would have speckles in that fluid. If it's just clear fluid, then it would just be, and you have a power Doppler of those red speckles from the vascularity, then you would be told that you have inflammation. If you have a positive power Doppler, but it's clear black fluid.
Okay, we have one more. I developed huge black bruises on my hips just from leaning on them while painting. Was this most likely a bleed in the joints, and should I have had it looked at?
Okay, hip joint is tricky. So if you have a true hip joint problem, it hurts when you do this. Okay, you can't turn your leg in. If you try to turn your foot up, it rotates the ball and socket joint, which is the hip joint. Okay, it'll rotate it and it'll impinge if there's swelling or blood in the joint. Hurts like heck. So, and you also won't be able to lay flat. Okay, so if there's blood in the joint, it's going to keep it bent a little bit. Kind of like an iliopsoas bleed. Your hip joint bleed works the same as an iliopsoas bleed if there's blood in the joint. If you have blood out here, that would be more of a soft tissue issue. You have a tissue issue. So that would be more of a soft tissue issue than when you have an actual hip joint ball and socket problem, you hurt in your groin. Okay, so probably not. It's probably a soft tissue problem.
Are there any more? Okay, that'll do it for our questions. Thank you for everyone who joined us.
Well, we have one more
online.
here. Here you go.
Oh, wait.
Uh-huh.
Hold on.
What you're doing is an art of interpretation. The human eye can distinguish from clear to totally black, about 19 shades of gray.
Correct.
I was in intelligence, and we would use a false color system to go to 32, 64, etc. It allows you to pick up all sorts of things. Do you have that built into this yet? It should be a fairly simple.
Yeah, we do. It's called your gain. So we can turn up the brightness, turn down the brightness. We can change our focal point. We can change the depth of focus for deep tissues versus surface tissues. So that's built into the machine, and it's automatic. All we have to do is dial the button. And so it's really built in as what we call a brightness or a gain button. You're gaining those shades of gray, or you're decreasing the shades of gray. Correct. I don't know if it goes all the way to 64, but we're expanding. Exactly. Yeah.
Any other questions from the folks here?
Okay. Well, thank you so much for everybody online. And we will see you. And for an in-person demonstration, go to your closest HTC and see if your PTs have ultrasound and they can show this to you in person. And for those in the room, we will have a demo. Okay.